So I'm going to talk about the changing paradigms and what is our role as cytopathologists and how things are changing and shifting in the world of pancreatic tumors, especially the solid pancreatic tumors. I'll take you through the journey so you'll get some historical perspective. And you will also know how we arrived at where we are in our practices and where probably we are going in the future and what our practice will look like probably in the future. So with that, I am at Rutgers Cancer Institute in New Jersey. And this is my designation and the institution. And when I always see this, I always want to see what the global problem is with the pancreatic tissue. So this is the GloboCan worldwide data analysis from 2022 of over 36 cancers, and they had data available from 185 countries. And of the 36 cancers, I chose the one that was related to pancreatic tumors. And as you can see, the age standardized incidence rate per 100,000 cases, if you see both in males and in females, most of the incidence that is seen is either in Europe, North America, Australia, and New Zealand. And then the lower incidences are seen in other parts of the world. Now, when we talk about the incidence, we also want to see how it affects the death rates. And here is another data on the public health or epidemiologic data that was identified. And I love this because it correlates the age standardized death rates with the social determinant index. And the affluent countries, based on the social determinant index, has a higher death rate with pancreatic tumors as compared to the other countries. Now we can go through this list and say, what are the causes for this kind of graph? But suffice it to say that in countries that are well-to-do, the death rates are also higher and there is higher incidence. And when I talk about the cytology piece of it, and when we talk about pancreatic carcinoma, the first publication that I could find was in 1949, published in Cancer from James Ewing. And we are all familiar with that name, with the name tumors after him. This is the picture that was presented from the duodenal drainage. The cells were identified, were called carcinoma, and this was done in New York. And I wanted to know at the time that in 1949, cytology was performed, where else it was done in major institutions in United States. So while I was at University of Pennsylvania, I looked up the previous information, and we were able to see that biliary drainage and the pancreatic lesions were also performed during the same period of time as in New York. So we feel that cytology has been around for pancreatic lesions for a long period of time. Now, be that as it may, the standard of care and the standard always has remained where if there is any lesion in the pancreas, goes to the surgeon, they remove it, and they will do this complex surgery and give it to the pathologist. Over a period of time from 1949 onwards, many investigators all across the world have tried to figure out the value of fine needle aspiration biopsy of the pancreas utilizing either percutaneous route, using CT guidance, utilizing the ERCP guidance. So there are whole different modalities that are utilized with fine needle aspiration biopsy. However, for the diagnostic purposes, it's still the patient goes to the surgeon, the resection is performed, and since late 80s or so, radiation and chemotherapy or adjuvant, neoadjuvant setting is done. It was not until 1992 that the endoscopic ultrasound guided fine needle aspiration was performed. And there were two institutions. One was in Denmark with Dr. Peter Willman, and in Indianapolis with Dr. Veersamma, was the one who started doing the EUS guided fine needle aspiration. So this is the very first publication that you will see. And Dr. Willman has also done a lot in this area. When we do all these things, cytology was not considered as something as the mainstream. It was always on the sidelines. When the patient went to surgeons, they always resected all these complex surgeries with mortality and morbidity that was highlighted. And pathologists only looked at the tissue after the fact, not beforehand. So things changed over a period of time. And when we talk about the fine needle aspiration, we learned quite a few things about cytology. One thing that we learned is that there are two types of pancreatic tumors if you look at it grossly. One that is epithelial rich, the one that has lot of fibrosis, it becomes very hard, so it is fibrogenic, and the tumor cells are incorporated within. So if you put a needle within the epithelial rich tumors, you will have cellular aspirates. If you put the needle within the fibrogenic areas, you will have less cellular aspirate, lot of fibrosis, and admixed within that will be tumor cells. These are a little bit harder for cytologists to make a diagnosis, and as a result, oftentimes pancreatic FNAs were called indeterminate diagnosis, atypical suspicious. If we have some cellularity like this, cytopathologists don't have a problem, and some of the older criteria, if you will look, they will say cellular sample is associated with pancreatic carcinoma as opposed to chronic pancreatitis. So we have to recognize that there are two different types of pancreatic tumors, one that initiates fibrosis, the one that doesn't initiate fibrosis. But both of them will give similar cytologic features. So we need to figure out where it comes to. So essentially, when we do that, when the clinicians are asking a cytologist, they want to know whether it is benign or malignant. They don't want to know anything in between. But because of the difficult aspirations, fewer aspirations, challenges associated with interpretation of pancreas, the rate of indeterminate diagnosis was very, very high. And therefore, this was not utilized as a common modality for diagnosis earlier. The goal is that we want to increase either benign or malignant diagnosis and reduce indeterminate diagnosis because that helps the clinicians treat the patients. They don't have to come again, and they don't have to spend a lot of time just for getting a diagnosis. So either we see the acinar cells and ductal cells and we call it benign, or we find these three-dimensional groups and prominent nucleoli, and these are the findings associated with malignancy. Anything in between, we just put into the indeterminate diagnosis. So my first interaction with the endoscopic ultrasound guided fine needle aspiration came in 1998 when I first started it at Baylor. And when I went to another institution, I said, okay, what is the status over there and what is going on? So I looked at the data from 1990 through 2002, and we found that till 1999, we only had 84 FNA cases, whereas in 2 years' time, when we started EUS-FNA program, we got within 2 years 96 specimens. So we were doing something right. And here is the data and the spread that you will find. The unsatisfactory rate dropped down considerably when we started our EUS-FNA service. Our ATPR rates also dropped down considerably, and we were able to give definitive interpretation in most of the cases. That changed to what the surgeons were doing. So in this graph, we are showing that when this is the FNA, and these are the surgicals that were associated with it. Till 1999, we had surgicals that were higher and FNAs were lower. Since 2000, when we started FNA, our FNA volume started increasing, and our combined FNA and surgical volume started increasing as well. So we said something is going on that we are doing right. And this was the very first case of pancreatic carcinoma that we had diagnosed when we started this EUS program. And here you can see that this is all the benign portion of it. And here you start to see the tumor associated with it. So this is the very first historic case for us. And we saw the data that we are doing something right and everybody is utilizing it. So I looked at what was going on and put together a very comprehensive analysis of all the organ sites that were accessed utilizing the endoscopic ultrasound guided fine needle aspiration. And in the literature since 1992, most of the publications that I saw were coming from the clinical colleagues. Pathology did not lead any of the publications at that time, except for this one, which is our group that published in 2002 with 103 cases. When we looked at it, the sensitivity, specificity, and accuracy rates were pretty high. We didn't have any false positive rates, which means that we didn't do any harm to the patient. And it appeared that if this is the data, then this technology is working out well on all hands all across. So when we published it, we said that this is going to be the standard of practice to obtain the samples from deep-seated organs in 2003. And it was associated with the editorial with Dr. Stanley, who said, okay, so this is revolutionizing our diagnostic approach. And he highlighted all the areas that you could aspirate utilizing EUS. And we have our experience that we said, and they agreed that this is going to be the modality of choice for many tumors. From 2003, look at 2005, and then it started crossing over onto our cytopathology books. This is Dr. Cross's 5th edition book. On the pancreas chapter, he highlighted utilization of EUS-FNA for the very first time. And he said this is the newer approach for small pancreatic tumors. And it required a close collaboration between the cytopathologist and endoscopist. And this is very, very important. I think this made the difference in how the things changed over a period of time. So when we say that EUS became popular, why did it become popular? And here is the reason why. If you look at all the publications, they say that 20% of the cases are resectable, 80% of them come to clinicians that are unresectable, which means that we are finding most patients when they are already grown and we cannot do anything. The idea is to find them early enough so that we can make a difference into what their outcomes are. With the advent of CT-guided FNAs and the percutaneous FNAs that were performed in 70s and 80s, the sensitivity of CT scan at the time was that it was not able to identify any tumor less than 2 centimeters with certainty, whereas EUS was able to identify lesions as small as 0.5 centimeter or even lower, which means that now we are finding tumors that are here in the preclinical stage rather than at the clinical stage. So it is very, very important for us to recognize why this became popular. We are now looking at smaller tumors that can be identified utilizing this technology. We also learned a lot. And as I said, we need to partner with our clinical colleagues or endosonographers. When our endosonographers started, they were able to recognize this as a normal pancreas. And then they started seeing this little bit of stranding all over the place, or the areas where there were complete lobulations that were identified, but there were tumors that were impinging onto the portal vein circulations. When we see that, and if you put the needle in, and we started correlating in the early days, and if you put the needle in here, you'll be able to see these flat sheets of two-dimensional groups, flat sheets. These are the ductal cells. And then you have these acinar cells that you can easily identify. Acinar cells are very granular, and they have two-tone cytoplasm. Towards the luminal side, it will have a different color. Towards the basal side, they will have zymogen granules associated with it. So this becomes normal, and we started recognizing this pattern. For the cases like this with occasional stranding that was seen, we started seeing fibrosis, inflammation, and still preservation of the acinar structures. So this is your early chronic pancreatitis. When the acinar cells start to go away, the lobules will be seen with ton of fibrosis all around it. And this is what we are seeing, that no acinar cells. This is just the stroma that is seen with inflammatory cells. And this is seen both with chronic pancreatitis and with autoimmune pancreatitis. More frequently, this lobulation, if you find this is with chronic pancreatitis, not with autoimmune. Autoimmune has a different pattern, and I will show it to you later. This becomes important because if I don't recognize what the clinicians are seeing, it can have an impact on how I evaluate cytology. Here it is very clear, right? There is a mass and they don't require me. They want me to say this is cancer. So when I go into the room, the endoscopy room, they're going to say, Nirag, you got to call it carcinoma. And then if I don't call it, they are not in the target area. So they will keep on going till the time they get the information. So if you put the needle in here, clearly this is malignancy. You are finding this targetoid appearance with a lot of mucin in it, single cells, pleomorphism that you are able to see, some small, some large cells, some closer. You are seeing this big, giant, ugly nuclei, which is more than 3 times the size of the red cells. So if you find this, it's easy to call something as carcinoma. So if I would see this and go into the room, I will be able to say what they are going to target. This helps me because it is important for me to know what the clinical patterns are. Simultaneously, the gastroenterologists have become very savvy so that when I say something, they will look at their area and say whether they got the lesions or not. But it was not the case in 2003. In 2004, Dr. Brugge, who is the chief of the GI unit at Mass General Hospital, wrote this very nice article on pancreatic fine needle aspiration, whether to perform or not to perform. Because at the time, the surgeons were saying, if it is a mass, we are going to take it out. We are not going to stay with fine needle aspiration because it is just one more thing that they do. There is no need for it because the therapy doesn't change. And when he wrote it, he said there are 3 modalities, either ultrasound, CT guided, or EUS-FNA. And in one study, they said that the CT or EUS guided FNAs are more sensitive in documenting malignancy than EUS. But they said EUS is very useful for difficult lesions. Whereas in our study that we published, we saw that EUS-FNA was superior to CT-guided FNA in obtaining adequate cells from the pancreatic neuroendocrine tumors. And we were also able to get cells so that we could perform immunohistochemical stains on the cell block. So there was a debate raging at the time of what is important and whether to do FNA or not. In 2005, the Japanese group wrote everything about the history of EUS-FNA and highlighted from 1980s when the linear array echoendoscope was identified. In 1992, with Peter Willman, he identified in Denmark the first FNA was performed. And from 1992 through 2005, they highlighted all publications that were highlighting EUS-FNA. And they asked, our endocrine neoplasm tumor also said that this is important. The same thing that comes from the Eastern Europe, they also put together the 25 years journey with the EUS-FNA, and they highlighted all important areas and publications that were highlighted till the time it was 2017. And we'll talk about some of this portion a little later. In 2005, because of all these publications coming out, and we said this is very, very important to identify small tumors, we will be able to make a diagnosis of carcinoma. NCCN guidelines for the very first time changed their recommendation in 2006, saying that biopsy or EUS-directed biopsy, which is preferred, not only for diagnosis, but you can also do the staging with it. And if it is biopsy positive, patient can get neoadjuvant chemoradiation and then surgical resection. So the therapy started changing. The paradigm shifted that from not doing FNA now they shifted it and said, we do need to do EUS guided biopsy since 2006. From then on, the things started changing across United States. So what did we learn? The pattern that we learned is that we started becoming better. We had less indeterminate diagnosis. So we said, okay, what did we do right? What did we learn? And what did other investigators learn in the process? And for cytopathologists, this is always the thing, right? Tissue is the issue. Adequate cells equates to adequate diagnosis. So how do we get it? The other important part was effective communication is necessary and identifying pitfalls. So we'll go through each one and we'll talk about it. And if somebody wants to see the publications, here are some of the publications that have come out, which talks about reducing the atypia rates and improving the adequacy of diagnosis with EUS-guided fine needle aspirations. So when I talk about adequacy and when I say on-site evaluation or ROSE is important, it is important to know when the clinicians or the endosonographers look at it, they will say, okay, this is a lesion. And they will say that for my pre-analytic probability based on this image, as I showed you before, whether it is going to be carcinoma or if it is well circumscribed, they will start talking endocrine neoplasia. So based on their demographics, the EUS finding, they will have their impression and they will say this is the target area. So they will put their needle in the target area. The important for pathologists is that when they give you the cells, are they really giving you the cells from the target lesion? And this becomes very important because oftentimes I had seen that when they say their needle is in the lesion, it actually, this is not a three-dimensional area, so it may be in another area in the normal process and they may not have received the target lesion. And at the time we said, once you have the sample obtained from target lesion, we should be able to say, okay, I can give morphology, but if you require additional ancillary testing, do I have enough cells to answer the relevant clinical question? So if I don't have this, even though I have cells on my slide, I don't call it adequate till the time I have those relevant cells available to me. So that was something that we did, and that helped us a lot. We also know that smaller lesions and larger lesions and how does it matter. So for cytopathologists, it doesn't matter if it is small lesion or a large lesion. If you give cells to pathologists or cytopathologists, they will be able to make the diagnosis. The question is, how do you enrich it? So we analyze the number of passes with the adequacy. So number of passes all the way up to 11 through the percentage of adequate samples. And we started plotting everything just for the pancreas. And we saw that for pancreas, even though the tumors were larger, we were requiring more number of passes as opposed to lymph node, liver, GI tract. Anywhere you talk about, we required less number of passes. Now, this was in 2004. Now, they have so much experience on the EUS end that they don't require more than 3 passes. And they don't require FNA, they start doing FNBs. So if you do more than 3 passes, it's going to reach the area of limited returns. And when we talk about these passes, it is associated with pathologist presence in the room to give the rapid on-site evaluation. So these are the publications, high number of cases. And if the pathologist or somebody is present in the room to give you the adequacy rates go above 94%. When pathologist or somebody is not in the room to give adequacy rates, they fall down to 80s, somewhere in low 80s or high 80s. This is coming from MD Anderson study in 2002. And our own study, we started seeing 96% adequacy rates when the pathologists were present. And the other part that we all started talking about is that when you have the on-site or real-time analysis that is performed, we find that the unsatisfactory rate reduces to 5% or less. The quality of slide is in our hands, so it becomes better. The number of slides also you can control. And the cost is low and the diagnostic accuracy is very, very high, which means the patient doesn't have to come again for an indeterminate diagnosis. But if the slides are prepared somewhere else and you send them, then you never know what kind of slides you will get. There is no quality associated with it, and oftentimes it is very bloody, so you do not know what to look for it. Now, this would take considerable amount of time from cytopathologists. We don't have physical space, maybe very, very far away. So to circumvent that piece, we started using dynamic telecytopathology or real-time telecytology for rapid on-site evaluations. And we were able to project whatever samples we prepared through the real-time image sharing. And we were able to give in the endoscopy suite whether the cases were adequate or not adequate. And we published our findings in 2006. And now at many institutions, it has become the standard of care. And if anybody wants to read how to validate the telecytology information, then ASC had put together the task force, and the publication is now in the Journal of American Society of Cytology in 2023 and 2024. So you'll be able to see that a lot of work has gone in for telecytopathology and on-site evaluations. And I always say that it is always in the eyes of the beholder, right? Cost of rows is when we spend a lot of time into the endoscopy suite, and oftentimes it is cost prohibitive because we spend an hour into the endoscopy suite, and that's not good. So when you want to provide rows, sometimes patient will say, I will pay from my pocket. You just come, you give the rows, and they don't care about how much cost, time, and everything else is. This is just a picture because I was called for 24 hours to go outside US, give rows, and come back. So when we talk about EUS-FNA, now we go on to the EUS-FNB part. And when we talk about EUS-FNB part, the first needle that was developed for EUS-FNB was actually a little earlier in early 2000. The true cut needle biopsy was performed, but nobody used it because it was very cumbersome steel and the alloy was very, very different. They came up with the Procore needle. Then they came up 5 years later, a fork tip needle that was marketed through different companies. And in 2017, they came up with the Franzen type needle or the acquired needle. So these are the three Procore, fork tip, and Franzen type needles are being used for FNB purposes. And when we talk about the FNB purposes, the Franzen needles in comparison to the eco-tip needle with the reverse bevel or fork tip needle with the reverse bevel, it appeared that both Franzen needles and fork tip needles give you a better sample in comparison to the reverse tip needle for FNB purposes. And we did the regression analysis, we did multivariate analysis, and it came out that we were able to get significantly better samples using these two rather than reverse tip needle. The other factors, I won't go into it because this is not the right forum for it, but you can have the stylet retraction, no suction or wet suction or, vacuum and heparin and everything else. So I'll not go into those details, but this becomes important that these two needles, when they are used, you can get the FNB portion of it. The gauge that goes from 22 to 19 gauge needles. Now I've seen even 25 gauge needles being performed. There are alloy needle with nitinol formation with 19 gauge needles so that it is much more pliable. So it has become very, very helpful for uncinate lesions of the pancreas. So when we talk about in the era of FNB, If you have a lesion in the pancreas, and here is the lesion in the pancreas, they say my needle was right there and it should have been there. And next day we see something like this, and everybody on this webinar will say you got these acinar cells, you have ductal cells, you have fibrosis, you have blood vessels. This is just the normal pancreas that we are seeing. So then you go back and see, this is the lesion. The needle never ever entered the lesion at all. It was right close on the surface, but not in the lesion. Now, if you are not on site, you have wasted 24 to 48 hours, and the patient will get the normal report, and it's an inadequate specimen. Instead, if somebody would have gone in, created the touch prep, you will be able to see the same, right? You are seeing the acinar cells. Here are the acinar cells. You can see these acinar structures, and you will be able to make the diagnosis by saying, well, this looks like the normal pancreatic tissue. Perhaps you are not in the target area. So ROSE still holds value in my eye, even when the FNBs are performed. You can save lot of things for the patients for their patient management purposes. Now here is another area that is developing in the field of gastroenterology, the sampling around the vascular channels. So here is one lesion where this is in the body of the pancreas. We are seeing this from the stomach, and there is a vessel in between, and there is no space for the gastroenterologist to go to the lesion unless they puncture the vessel. So now they are able to do it. Here is the way in which they are putting the needle in. But for this, FNA is preferred over FNB needles, especially when the thin wall vessels are to be traversed. This has to be done very carefully because there may be bleeding associated with it. So they prefer 25 gauge over 22 or 19 gauge needle. And for them to get it, they want ROSE to be performed for these kinds of lesions because they don't want to keep going into the lesion and create any bleeding diathesis for the patients. Here is the other example where there is a tumor thrombi within the vessel, in the portal vessels. And here is the ERCP in a 51-year-old. The ERCP was performed. They were able to see all these channels. And on the vascular channel, when they looked at the EUS, and you are seeing this Doppler effect, that this is the vascular channel. And then you had to put the needle within the vascular channel, identify that lesion, and you give the FNA sample, and this is what it will show. And here, this is two-dimensional ductal structures and adenocarcinoma that was very much visible here. So if you go into the vascular channels, you can use FNA if it is a thin wall vessel. You can use FNB needle if it is a thick wall vessel. Now, this is important because we may be called to say that we need you to be present in the endoscopy suite. More and more gastroenterologists now only perform FNB, but in these scenarios, they may require pathologists to go on site and give the information to them so that they don't have to do multiple passes. So ROSE is a critical step in these scenarios. So let's go to the other areas where we identify the pitfalls and reduce atypias. So when we first published our in 2003, we said if the lesion is in the head or uncinate, the approach is transduodenal. And if you go transduodenal, then you may be able to see the goblet cells, the glandular cells, and honeycomb appearing cells with the wall in the duodenum. Body or tail goes through transgastric route. Parietal cells and chief cells may be seen along with the glandular cells of the foveolar cells of the stomach may be noted. So you can find these as additional cells in your FNA material when you are aspirating from pancreas. And this was a big pitfall. So CAP highlighted this in 2005 in their special section saying that depending on the topographic location and the lesion in the pancreas, EUS-FNA will sample different types in the normal GI structures. Later on, in 2015, we started seeing some resections being performed for the atypical cells that were seen, very prominent nucleoli, and the cells were scattered, lot of apoptosis and falling apart. This was coming from the Brunner's gland, and it became a pitfall for many of the lesions that were coming from consoles. The other feature that we started looking at it, because of our experience, we said if it is a cellular sample, if it has groups of cells, if it is predominantly ductal cells, it is going to be adenocarcinoma. We can go through all the other criteria for adenocarcinoma, but when you are on site and if somebody is looking over your shoulder and you have to give it within a few seconds the diagnosis, this algorithm really helps that if you are in there, if you are having single plasmacytoid cells, this is your differential, so you know exactly what you want to collect for the ancillary studies. And this has been published in 2 books, so anybody can utilize it. The gastroenterologist started saying that since in many countries, ROSE is not available, so they wanted to do it on their own. So this was a study performed by the gastroenterologist from 11 countries. And they said that once you teach everybody to use this algorithm for ROSE, they will be able to perform it in their own practices without any problems. So they found it very useful, and many of the cytopathologists found it very useful. So the third piece comes in is standardizing reporting. What I call something here is adenocarcinoma. Anybody across the world should be able to do the same. And this was a very important undertaking done by Dr. Schmidt, Dr. Field, and Dr. Martha Pittman. And they identified all the subject matter experts in pancreatic cytology and came up with this standardized format of reporting in WHO. So this is available and everybody should start using it because it provides a lot of criteria for cytologists. Then we go to the second opinion and judicious use of ancillary studies. And Papanicolaou Society put together the group of investigators and said, what are the important things for pancreatic tumors? And they identified mesothelin and SMAD4 because there was a validation and there were different investigators who had worked on it to give the information. Now, this is in 2014. We are now in 2025. There are a number of other markers that have been utilized, but these still hold true if you want to utilize it. You can also use multi-probe FISH analysis. And if you see amplification in CEP3, 17, and 7, then you will be able to suggest that if somebody is going to call this suspicious, if you find amplification of these probes, then you may call it carcinoma, and it has worked and has been noted by other investigators as well. So you can use immunohistochemical stain, or you can utilize FISH probes to come to the diagnosis. So here is the first case. Your male 56 years, this is the ERCP. You are seeing that there is a stricture over here in the pancreatic duct, and there was a stent placed, and there is the needle that goes through. The clinical consideration was whether this is chronic pancreatitis versus pancreatic carcinoma. And this picture is available to you. And you can see that this is a Pap stain smear where there is closed cells and cells away from each other. This is a drunken honeycomb appearance. I always say that long axis of one nucleus is not the same as the long axis of other nucleus. We are seeing this marked membrane irregularity. We're seeing prominent nucleoli. This is carcinoma and has to be recognized as such, even though you are not seeing any single cells or anything like that. These are group of cells. And here is for comparison purposes, the two-dimensional cohesive ductal cells, they will go in the same direction and there is no loss of polarity. There is no increase in the nuclei or enlargement of nuclei or membrane irregularity associated with it. Now, as I showed you, over a period of time, number of investigators have given us what should be considered as pancreatic carcinoma or cytologic features, and these are highlighted. So you can have three-dimensional groups, you can have drunken honeycomb appearances, you can have abortive gland formation, you can have necrotic background, prominent nucleoli, occasional mitotic activity, you can have squamoid cytoplasm, single cells, And this is a very soft criteria of intranuclear inclusion. If you see this, then you should look for other features associated with it to make a diagnosis of carcinoma. So there are a number of features that are associated with pancreatic carcinoma that are very, very helpful. And oftentimes, you may find the macrophages and the carcinoma look very, very similar. But for macrophages, you'll see that the nuclei may be enlarged or there may be prominent nucleoli, but you will continue to see that the membrane irregularity is not there, and you'll be able to see the hemosiderin within the foamy macrophages associated with it. Whereas in foam cells, you'll be able to see this membrane irregularity. Even when this is a Diftwick or Romanowski stain, you will be able to recognize carcinoma very easily, except for the cytoplasmic features. Often the mimickers are when you have this group of cells with ton of cytoplasm that pushes the nucleus to the periphery, almost giving like a signet ring appearance. If you have a three-dimensional groups coming from the gastric foveolar epithelia, you can start to see that maybe there is this mucin in there, and the nucleus is pushed to the periphery. But the regularity of the nuclei, no membrane irregularity, all those features taken together will make this carcinoma, and this has benign. So what did all this do? So this was in 2005. New cases estimated were only 32,000 in United States, and 31,000 patients succumbed to the disease during that year. What happened in 2025? The statistics are changed. The estimated number of cases have increased, most likely because now EUS is being utilized more frequently, so we are finding new cases, and the death rates are not as much. 98% of the patients would be here. Only 77%, which means that there is improvement in the survival rates associated with what we have done so far. What has happened in 2024, the NCCN changed its guidelines once again, and they said, we do require biopsy if not previously done. They prefer EUS-guided biopsy, FNA or FNB. They prefer FNB. And they say it should be performed at the multidisciplinary expertise where there is available. And they now say that genetic testing for the inherited mutation is very, very important. So not only do we do the NGS for DNA and RNA fusion panels based on NGS pattern, but also you have to do germline testing. This is coming towards now the comprehensive cancer care with the EUS-FNA sample that you can find. So the workup becomes very different. So what becomes important? So when we talk about the molecular profiling, we did our study and said, okay, how many passes do we need to get the adequate DNA and RNA extractions? And it appeared in our study that only 2 passes are necessary. You don't have to do 3 passes. And this was now highlighted in the 2024 NCCN guideline that 2 extra needle passes should be performed to perform the NGS analysis. And so this becomes important, that once we have this data, we are able to say that this becomes the checklist item, if you will, for doing the molecular analysis, because things are changing. So now what I told you is that pre-analytic probability confirmation that the sample is obtained from target lesion. Do we have immunohistochemical stains that can be performed? We have to go one more step and say, do we have cells to perform genomic and germline testing? And here is our data from the paper that I showed you, where you have some cases with BRCA1 mutations or TERT mutations that will be seen. BRCA1 mutation will be associated with the HRR mutation panels, and treatment for them is different because for them, you use the platinum-based therapy, you don't use the gemcitabine or FOLFIRINOX. So we put together in NCCN and said that we do require the resources to perform genomic and germline testing in pathology labs, as well as we need to do the germline testing at the time or obtain the sample at the time we perform ROSE. If we do that, not only do we give patient a chance for platinum-based therapy, but we also offer a chance for the family members for counseling purposes. So this becomes a comprehensive process if you do the rows for germline testing at the time when you make the diagnosis. Did it make an impact? It definitely did make an impact, right? In 1992, the first EUS-FNA was performed. 2006, the NCCN recommendation changed where EUS was going to be performed, and the survival rates have now become 12.8%. For the very first time since 1975, when it was 2% survival rate, now we are at 12.8% survival rate. So it's a huge difference with the advent of EUS-guided fine needle aspirations, and so we become very important. And as I said, the standardization for pancreatic carcinoma was performed. So these are the people who contributed in that. We are also going in the area of whole slide imaging with machine learning. And that is going to be the another front that we will come across in 5 or 6 years later. So for the surgeons, this is the Time magazine. This was our chief of surgery who was performing the surgeon, and they took a picture. You can see the pancreas right in his eyes. From diagnosis, they are now important only for management piece. They don't go in and say, we are going to take it out. They will ask somebody else in the chain, such as cytopathologists, to come in, give them the information for staging and what kind of tumor, so that you can have a personalized therapy for patients with pancreatic tumor. Now, we also have 5 or 7 minutes left. So female 63 years, EUS 2.8 centimeter heterogeneous mass of the pancreas with stranding was seen. Also revealed enlarged lymph node in the mediastinum. So their concern was that we have to rule out pancreatic carcinoma. So here is the EUS finding, and I said I will talk about the EUS finding another time, right? So in this EUS finding, the entire pancreas is enlarged, and there is a fibrous strand going in. It's not lobule, it is the fibrous strands that will go through. If you find this pattern, it is associated with one particular lesion. If you put the needle in, and if you find that there is this lymphoplasmacytic infiltrate, you will find these acinar cells and ductal cells, and often reactive ductal epithelium, and then fibrous tissue will be seen in an haphazard manner. This was done through FNA material, and at that point in time, you are seeing that this is a diagnosis where you have imaging study, your morphology, with reactive pattern. Look at this. Although the cells are enlarged in prominent nucleoli, they are going like a school of fish in one direction. The membrane is round and regular, and there is hypochromasia. This is a pattern that is associated with a reactive ductal epithelium. This is not carcinoma, even though every cell looks tumor-like. This is benign condition. So if you utilize it with the pattern that you have here, then you have lymphoplasmacytic infiltrate, ductal epithelial cells, acinar cells, fibrosis, and this epithelium. So you are in the differential diagnosis of chronic pancreatitis and autoimmune pancreatitis. With the EUS finding that you saw, one has to consider IgG4 levels for autoimmune pancreatitis. Now, those are the times when we were doing FNA, and we were seeing some publications where there were false positive diagnoses of carcinoma that were done. With the FNB needle, it is very, very helpful for FNB needles. So here is an example where they had done 2 or 3 passes for FNB core. You are able to see the phlebitis with inflammatory cells, especially the plasma cells that are seen. You are seeing ton of lymphoplasmacytic epithelium with destruction of acinar cells. And this is CD138 highlighting all the plasma cells that are present over there. And of these, there are a number of IgG4 positive cells that are present. One can also do serum IgG4 levels. And one also can see this is part of the systemic IgG4 pattern as well. So in this scenario, FNB is preferable over FNA in my experience. And here is the last case, 33-year-old presented with abdominal pain. CT of the abdomen revealed a pancreatic tail mass. And if you start looking at it, this is the pancreatic tail mass. 33-year-old, this becomes very important when you give a young patient solid mass, very well circumscribed mass. Our differentials are limited, not cystic. This is a solid mass with some necrosis in the center. If you find this pattern, then it is neuroendocrine tumor or solid pseudopapillary neoplasm of the pancreas. If you find this fibrovascular core, then it is associated with the solid pseudopapillary neoplasm of the pancreas. If you look at the nuclei, you will find this coffee bean appearance. So I just put coffee beans for your just analysis. So here is the nuclei. One other pattern that you find with solid pseudopapillary neoplasm and that I found very useful is that the nucleus will be going away from the fibrovascular core. So they are aligned away from the fibrovascular core. The cytoplasm will be towards the fibrovascular core. You can find single cells. They will be plasmacytoid cells. You will find cytoplasmic vacuoles. You may find PAS positive pattern within the cytoplasm here. Or you can find the metachromatic matrix material. As opposed to that, with endocrine neoplasm, you may find some fibrosis. You may find plasmacytoid cells. In the cytoplasm, you will find these granules that are present, or neurosecretory granules. You may find some vacuoles within the cytoplasm, but when you find them, they are very small, smaller than the size of the diameter of the nucleus. If you find the vacuoles that are larger or equal to the size of the diameter of the nucleus, that is associated with solid pseudopapillary neoplasm of the pancreas. So that's another morphologic feature to keep in mind. You can also find this rosette formation with pancreatic endocrine neoplasia. If you want to perform the stains, then beta-catenin positive is seen with solid pseudopapillary neoplasm. And here is the morphologic feature that I was talking about. If you find this large cytoplasmic vacuoles, it's associated with clear cell variant of solid pseudopapillary neoplasm. It's rare, but has been reported by additional investigators. And as I said, we are going into the era of molecular diagnostics with whole slide imaging. And a lot of models are being analyzed and developed so that you have the molecular pattern that you'll be able to see on your H&E slides with EUS-FNB needles, and they will have the prognostication associated with it. So this is a tile-based molecular analysis from the H&E stains that is developing, and we'll be able to figure out in the future utilization of AI technology in our daily patterns. So the paradigm is changing. Previously, it was from histology went to cytology. And now we are going in the other direction where we are seeing small tissue cores more frequently. So we are seeing small cores. ROSE is a missed opportunity at many institutions. So wherever is possible, I would urge everyone to say that we want to go for ROSE. We want to have molecular testing done at the time of diagnosis. With that, I thank you all.